So, hello everybody. I welcome you to the Tree Academy online webinar today with Dr. Alecsandru Ionescu from Romania. And I'm very happy for this Tree webinar today. My name is Holger Kast. I am a dental technician, did work 8 years long in the headquarters for Straumann in Basel, and there I was involved in all developings of the prosthetic for bone level implants and also for tissue level implants. And today the tissue level is the topic more or less. So our topic is Back to the Future, Aesthetic Biological Concepts for Long-Term Aesthetic Results with Tissue Level Implants with Dr. Alecsandru Ionescu. But before I give the word to Dr. Alecsandru Ionescu, I would like to shortly give you a little overview of the tree implant system, which is basically has three different implant types. There's the narrow implant, there's a three-vent implant, which are both bone level implants. And then there is the tissue level implant, which we have to focus today on. And all this you can implement like with this lean surgical kit. All these three implant types you can implement in the patients with this small surgical kit. And we have also the new packaging, which is the tree-pot, where we are really proud because it's a really touchless and free, very clean packaging, which is revolutionary in the implant industry. So as I already said, the focus today is tissue level implants, and here is a picture of our 3-octa implant, which is the tissue level, and everybody can also already see that our tissue level implant has this pink color coding, which is an anodizing process, which makes the implant here in this polished area pink, which is scientifically proven a better aesthetical result. And the reason why our 3-octa has a pink implant neck is, as you can see here, this is a picture of a standard titanium implant, a tissue level implant with a very narrow tissue, as you can see here. And then there's sometimes aesthetically the problem that the color of the titanium shines through, especially in the aesthetic region of front teeth. So that's why we did, or the University of Zurich did actually a scientific study where they tested different colors of titanium underneath a 1 millimeter thick gingiva. The first here on the left side, you can see the titanium color. So they placed titanium clear from normal tissue level titanium color underneath 1 millimeter thick gingiva, and they placed also titanium anodized with gold, which is also a common color they use in the implant industry. And then also the pink color from our tissue level implant, and the zirconium, which is a white color like a natural teeth. And here you can see there's significantly difference between the titanium and the pink colored anodized titanium. So the aesthetical aspect is almost the same like if you place a zirconium implant underneath a thin tissue, and this aesthetic aspect is significant, which I'm very sure that Alecsandru Ionescu is explaining in his presentation also. So from my side, I'm very, very excited for the next common hour with Dr. Alecsandru Ionescu from Bucharest. He's already here waiting, and I'm happy to give the word to Dr. Alecsandru Ionescu right now. And please, Alex, go ahead and introduce yourself and start with your great presentation. I give you the rights to your presentation. 1 second, are you doing this? Okay, Alex. Hello, Alex.
Okay. Hello, everybody. Thank you for your introduction. I am Dr. Alecsandru Ionescu from Bucharest, Romania. I am somehow dedicated to my last years to the minimally invasive implant surgery that usually is going to achieve aesthetic results. For that, I'm going to give you like a 1-hour presentation with brief points of our concept and philosophy. What I want to say is that, you know, many roads bring you to Rome. This is just another way. For people who already have great aesthetic and surgical concepts, it's just an alternative, such as you can just have it as a backup. For other people who just love the biological concept, maybe it's just a new way of seeing things. So first of all, I'm not so used with online presentations. Usually I like to see people in front of me explain and interact with them. It's something new for me. I accepted the challenge from Holger and from Tree for that. So if there is any, let's say, miscommunication between me and you, it's just that I just talk to my computers, not to your presence. So for that, we will probably back up in another face-to-face meeting, maybe somewhere in this world. Okay.
Maybe Alex, shortly, I just want to give our participants the information. If you have questions during his presentation, please use on your side, please use the chat button and write down your questions. I am going to look at them all the time and write them down. And at the end of Dr. Ionescu's presentation, we're going to have time to answer all your questions. Okay, go ahead. Thank you.
Okay, so the main aspect of our philosophy is that we are trying to enjoy what we are doing. So this is what minimal invasive implant dentistry is nowadays. This is part of me having a surgery during a live OP with other doctors in our office. And this is the happy patient afterwards. The philosophy is that we just like to have happy patients. Then we are going to focus on the patient comfort, which is something that sometimes very big surgeons forget about, is focusing on the main, let's say, surgical result. This type of situation happened to us, probably happened to you. On the left side of the screen is a patient that came to us after a bilateral sinus lift that she had in a maxillofacial surgery in the university, and she was just frightened of what happened. So I tried to find another picture with a similar case in our database, but I couldn't find. And on the right side is one of our everyday surgery patients with sinus lift and immediate implant placement at flapless tissue level. So basically what we need is to keep the smile of the patients on their faces, not on our faces, as a result of our, let's say, brave surgical skills. So patient comfort, it's very important nowadays. What do our patients want? Something like this. This is the final result of our patient that you just saw a little bit earlier. They just want very nice teeth. They don't want to have multiple surgery stages. They don't want to have problems after surgery. They just they just want to have beautiful teeth. So, what type of implants shall we use to be as minimally invasive as possible? And the same question, what type of implants shall we use for high aesthetic outcome? Now, you know that there is a, let's say, a common idea that especially for aesthetic zone, there is a somehow contradiction between tissue level implants and high aesthetic. One of our key points for today will be this, to show you how we take care of aesthetic cases with tissue level implants. The thing is that I am using in my office exclusively tissue level implants for, I think that's pretty much 10 years already. So we switched like 10 years ago. We were trying to use both bone level and tissue level, and then we were having bad results with both of them. So we have decided to go only one direction, and that direction was tissue level. Again, I'm not saying that there is no good thing in using bone level. No, it's just an alternative for high aesthetic outcome and very stable results. So our main points for today will be aesthetics and minimally invasive for patient comfort. And a final result in our office with the tissue level implant. So this is what the patient really wants. No multiple bone augmentation, no swellings, just very nice teeth. And as soon as possible. We learned in the last 10 years after using these biological concepts that originally came from Dr. Dennis Tarnow from the United States and from my friend and partner in Germany, Dr. Gerd Taffet. We just respect biology, and the biology will respect our treatments. Now we start with the idea of flapless insertion for better patient comfort. And we go back to our everyday practice with a clinical case. So in the first picture is just the sign from the provisional the patient had. We just made a punch and we had to elevate the sinus floor internally and place the first 3-octa ping neck ever inserted. It was like 2.5 years ago. This type of surgery usually takes like 10 minutes, and the patient is very, let's say, happy afterwards. Now I'm going to show you the X-ray before. Of course, we did the root canal on the adjacent teeth. You can see the sinus. Of course, it's a limit, and we are close to 8 millimeters. That's why we decided to elevate the sinus floor internally without a normal sinus floor elevation. You can see the fracture after the sinus floor elevation and the membrane there. So this is immediately post-op, and this is the 4.1 by 8 millimeters 3-octa, as I said, the first 3-octa inserted. And the final restoration with the ceramic on zirconia crown, and this is the aspect immediately after the crown cementation. You can see here the papilla, and I'm going to show it to you now on a 2 years follow-up, such as we understand how biology is working. Here it is. 2 years follow-up, papilla is back. There is no sign of any inflammation. Here is a section from the computer tomograph. So we did a CBCT to see exactly what's going on there. You see we did not lose any bone at all, and the same aspect of the sinus floor internal elevation. Biology and reorganized our soft tissue, just biology, without anything. We respect Dennis-Turner's rules, so we have from the contact point to the bone 5 millimeters. This is available for natural teeth and for implants as well. So you see, it was suffering a little bit from the previous intervention that the patient had before she came to us, and now after 2 years, without any other intervention, you can see the nice outcome of the soft tissue. I started with a basic case just because people who are coming to our courses with live OP and hands-ons usually are asking, okay, how do we start? And we always tell them that they need to start with something straightforward. But how do we get a straightforward case? Because nowadays we extract a lot of teeth. Everybody is probably doing socket preservation and all these things to prepare. What we are doing is we are preparing our sites from the beginning. So this is a case. Here it's the initial situation, and here is our case after 6 months. We call this open healing protocol. Of course, we don't extract the teeth like this. We just section all the roots. Otherwise, we might have this type of result. Okay, all of you met this situation, but we want this situation, which is something else, and allow us to start with a straightforward flapless implant insertion. Just a quick word about the open healing. So it's extraction. We cut the teeth. Here is the clinical situation. It's not the topic for today, but we don't do any flap. This is the main point of the day. Flapless for everything, no flap at all. So this is how it looks after 30 days. And the flapless implant insertion, just going through the gingiva. We take out the punch. The punch always needs to be sized a little bit less than the diameter of the implant. And we consider that having 4.8, the diameter of the tissue level implant neck, pretty much we use the 4 millimeters diameter punch. So this is how it looked like. Remember where we started? As we did not raise any flap, neither for the socket preservation. Here you can see the BIOS, how it looks like after 6 months, and the implant placement. Of course, just a little internal sinus lift elevation. We had a 10 millimeters implant. So we did not lose anything at all with this case. Now, aesthetic zone. Everybody is afraid of aesthetic zone. In the aesthetic zone, we are able to place the implant immediately after extraction, usually only when we have the buccal plate present. So when the buccal plate is totally disappeared, we need to do the same protocol. This is the original technique that was presented many years ago by Dennis Turner, and it's called the ice cream cone technique. And we modified a little bit. because it's better for us, for the final result, to have everything, all the contour and everything normal like for the natural teeth. Again, no flap, nothing. We don't use any blade. This is the outcome, and this is the implant inserted after 6 months. And this is the CBCT before, CBCT after the open healing protocol, and the CBCT after 6 months. So you see there is no bone loss at all with this flapless protocol. Implant insertion, all the time we are trying to insert the high diameter implants in the aesthetic zone, because we are expanding, when we place the implant, we are expanding after we have the first 2 drills, we are expanding with the bone expanders from the interior, such as we get the volume of the adjacent teeth. If we place here a narrow implant or a thin implant, what is going to happen, we will need another buccal augmentation to have the same design of the soft tissue. And a comparison of the CBCTs before and after 6 months recall. So there is no bone loss at all. We can see we are at the thread and at the polished neck. The rule with a tissue level implant is that we need to place the implant, the threads, at the bone level. The rest of the implant is going to be above the bone. And I'm going to show you later how we do in the aesthetic zone and how important and outstanding was the new pink anodized neck of the 3 octa in our everyday practice. So again, this is a situation where the buccal bone was present, so we were able to insert the implant. You will see now the healing. It's a very good healing that is going to our second topic. With this type of healing, we always preserve the papilla. We don't touch with any blade, anything, and the papilla is going to be formed immediately according to the shape of the implant. So basically, the shape of the tissue level implants are designed to preserve the papilla. And now, this is the final result with a crown. Of course, we are all the time we take care of the adjacent teeth. If they had previous root canals, we ask our endodontist to make sure that everything is okay. I don't want to have any problems from any other sides. You can see the bone level, it's there, and here there are 5 millimeters from the contact point, less than 5 millimeters from the contact point to the bone. This is going to assure my papilla it's going to be there for the rest of the period of the patient, unless he's going to start lose bone because he's going to be older. So this is the situation before the treatment with a tooth that was not able to be saved, the implant placement, the CBCT before and 6 months after. So these are going, these minimally invasive concepts with the open healing and the tissue level implants are going hand in hand for this predictable aesthetic and biological result. And the before and after cementation X-ray. Now, as I said, we are going to focus on a concept to preserve the papilla. All the time we want to have this type of results. Usually, for implants, it's not very easy to have this papilla after many years, or to have this, let's say, orange-shaped type of soft tissue. But if we respect biology, it's quite a good chance to achieve this result. Now I'm not going to insist on that. It's a very, very nice sketch. It was done by Dr. Anthony Sklar and it was published in 2003, so it's 13 years ago. And the comparison of the biological width in human dentition versus implants. As you see, it was the comparison was done with a tissue level implant, mainly because at that time they had more experience with a tissue level implant. And second, and most important for our discussion today, is that this is the implant that really supports the reproduction of biological width in implants. And this is the comparison. I'm not going to insist. I'm sure everybody is very familiar with this. So what is happening when we do not respect the biological width? It's bone remodeling. We all complain or used to complain about bone remodeling, especially around implants and especially around bone level implants. This is another sketch with a comparison of the bone and tissue level at the time of the bone level placement of a bone level implant and how it was remodeled as a biological width after the implant went to function. This is another very large topic on how to maintain this bone with a tissue level implant, but the idea is that the biological width follows the alveolar crest margin where there is enough space above, so at least 2 millimeters. And the same generates bone remodeling where there is not enough space. So this conclusion is available both for natural teeth and implants. What I'm trying to say is that is there the bone resorption around the bone level implant a mystery, or it's just biology? Considering that we respect all the other aspects and we just place an implant to the bone level and we have a thin biotype, less than 2 millimeters, the bone is going to resorb just to recreate its original state of biological width. Of course, there are different tricks with a bone level implant that can maintain the balance, so I'm not expert in that. I only just want to say that biology is sometimes our friend, and when do not respect, it can become our enemy. Now, predictable long-term aesthetic results in implant patients. I'm going just to talk briefly about the prosthetic protocol described by Dr. Taffet. So we are seeing the connection between the abutment and the tissue level implant as the natural tooth, and we prepare it just like that. And we just take the impression just like that, either digital impression or normal impression. I had a question from a very important professor in Romania at a congress. I was having a statement last year, and he asked me, okay, now is all this, let's say, customization of abutments and all these things, isn't it a challenge for the doctor to proceed this, and it's maybe a higher risk of let's say, adaptation of the crown? And I said, okay, for someone who is who is very good in preparing teeth, making high-end aesthetic and functional rehabilitation on natural teeth, it will be the same with a very, very predictable result. For someone who is not good on doing that, it's not a good idea. So you need to be or to have a good prosthetician, such as to have this type of results. And this is just a 10 years follow-up for a very old case with papilla on this type of situation that I explained to you. I'm going to show you some more details. So what about the thin biotype? When we can see from the gingiva, we can see the maybe the neck of the implant. 3 came to with a solution of the anodized pink neck, so we tried it. This is a picture we took last night. Holger asked me to have a picture with a latest tripod, and we did some surgery last night, and it was the tripod which is working very, very nice in terms of handling. So you saw this. I took the same explanation from with the 3 anodized. You can see there is a very, very similar situation with the zirconium. So it's pretty much the best result we can get from transferring the gingiva. What we do when the neck is above the gingiva, we just take the special burr for titanium and put like 0.5 millimeters beneath the gingiva, as you do in any aesthetic natural teeth. Now, why tissue level implants? We have better biological and mechanical integration. We can get higher aesthetic outcome due to the lack of incisions. Any incision in the aesthetic zone, even with the best surgeon, will generate at least a slight modification of the gingival aspect. Better soft tissue healing, because we do not make any damage to the periosteum. Everything is going to be very well healed, and the patient will get the best comfort for the same situation. And we can respect the biological width, as I showed you in the sketch with a comparison with a natural tooth. This is a key for long-term aesthetic results. This is a key for having papilla there after 10 years. The key is to respect this biological width and to have the second rule of Tarnow with the contact points. Otherwise, in natural teeth and implants, we are going to have soft tissue remodulation. Now, back to our everyday practice. So this patient was 73 years old when he came to us. He used to be a tennis player. He was training our national team for Davis Cup, and he was my tennis trainer at that time. So he was a very healthy person. We had this problem in the second quadrant, and we just wanted to try to be as minimally invasive as possible. Seeing this X-ray took us to the thought that we might be forced to do a sinus floor elevation. This is the CBCT. You can see there is a very small residual bone here. Same here. And the level of the first tooth that was about to be saved, and the difference between the bone here and the bone that he had at the mesial point is quite big. If we took out this teeth and just waited for healing and then proceed with the sinus floor elevation, starting from 7 millimeters above, okay, the surgery would have gone great, but what about, let's say, some teeth, prosthetically speaking, that are pretty much long, the length of the implant, and the difference between the bone level here and the bone that we got there. So we were thinking of a minimal invasive alternative. So this is the clinical situation before. We are trying to treat pretty much all the patients with the same approach. Aesthetic has no limits. We care about aesthetic. Even the patient is old. We care about function, same, and we care about the comfort. Even the patient is very young. So it's like the curve of balance with aesthetic, comfort, and function. For that, it was, again, it's flapless. We just took out like 1.5 millimeters to be able to screw this titanium mesh. There is no other flap. It was like a tent technique modified with open healing. So we placed above this, we placed the BioGuide. So the same concept, we were waiting. After 1 month, we took out the sutures. All the time we use the PTFE sutures. We don't have any other sutures in our office. I placed on purpose this just to have it on my presentation to say, okay, if you have these sutures in your office, for this concept of open healing, you just can't forget about it and throw it away. Okay, the healing 6 months after. So this is the X-ray before we took out the titanium mesh. You can see the level of the bone is here. So we just maintain this very, very, very small and thin plate, and we regenerated the bone in the rest of the site. Now we took out the titanium mesh. We left for 1 more week. So this is the, let's say, most invasive thing that we did. Flapless insertion. Then after 4 months, again, the prosthetic, we just put there the abutments. We took the impression, and this is the final result. You can see after the cementation, this is our X-ray. We had here an internal sinus floor elevation. We had here the bone up to 8.5, and we wanted to place 10 millimeters implant. Of course, it's the same. It was the same, I think, if we placed 8 millimeters like we did here in the front. But this is the soft tissue immediately after the cementation. And now, the 2 years follow-up. Look at the papilla. Remember, meanwhile, he is 75. It's not like he's like a 20 years young people that brushing with flossing and all these things, but he has a good hygiene. He's non-smoker. He's a very healthy person. This is a CBC taken from a CBCT. That it's a little bit different. I'm going to show you the entire CBCT scan. So before and after, this is what we gain and what we maintain because we use the tissue level implants. Okay, so it's a 2 years follow-up. The CBCT, there is a very small sinus membrane irritation here. It's normal after internal sinus floor elevation. So everything else is on place. Now, don't look at this implant. We are dealing with a problem here at the lateral incisor. We did this like 4 or 5 years before this X-ray. We finalized microscope endo treatment with a minimally invasive, let's say, endodontic surgical approach, and everything was okay. After 4 years, the patient came, said, okay, I have some fistula here. We did this x-ray and we couldn't see anything. This is 4 years ago, and after 4 years, look, we cannot see anything. But after we did the CT scan, this huge area was a cyst. Here is a CBCT scan. Look how big was the defect. Now, we are trying to think minimally invasive for all our cases. In such a case, we wanted to proceed with a one-stage surgery. Was it possible? This was the defect. This was the lateral. The canine and the central were not affected, were the positive result of the vitality test. So if we were face to face, I would ask you, what was your approach here? Of course, there were different types of approaches. In the end of the day, we need to take out the cyst, to regenerate the bone, and to place an implant, and to have a crown on the implant. These are the steps. Either we do them in one stage or we do them in sequential stages. Okay, so this is the initial situation. We took out the tooth. We did not touch the papilla at all. We tried to have a direct approach where the cyst was. Here, the buccal bone was present. So from the free gingival margin until we had this incision, horizontal incision, we had a bone present. The papillae were present. We did not touch anything. We didn't want to bother the biology. So extraction, cyst removal, we put some bios here. Suture the place, and then, okay, let's try to insert a tissue level implant. And this is what we did. And no flap. We only had the incision here for cyst removal. The post-op aspect, we place a rubber dam to attach. We prepared the in-lab provisional. We did this type of provisional. At that time, we didn't use any membrane. We can use cyanoacrylate around the implant if the gap is more than 3 or 4 millimeters. And this is how the patient came, and this is how the patient left. This is 2012. So in the end, she didn't want to change anything with her upper frontals, like veneers or something. So we had to focus on maintaining that. She had the function okay with cannon guidance and anterior guidance. So this is how it healed. Follow-up for healing. This design of the future tooth, the mock-up. This is how we do with all the cases, even we have only one tooth or we have aesthetic rehabilitation. As I said, we prepared like in the natural tooth impression. At that time, we did it with a regular impression, not digital, but you can do it digital as well. And the crown, which is scalloped here, according to the protocol of Dr. Tafe. So immediately after cementation, and this is a 4 years follow-up, so you can see there is no inflammation and no modification at all with a papilla present there. Before, after, it's again CBCT versus X-ray. That's why it's a little bit different when you see it here, but the bone was at the same level here and here after 4 years. Now, I see we still have 5 minutes before the questions. We are going now to the last topic, the bone splitting, the type of bone splitting that we are doing, again, minimally invasive. For that, we have a separate module in our office usually, but I'm going to show you the concept, which is basically very, very simple, and it's quite without risks. So we do not do any flake. We just make an incision on the crest. Then we just go like, depending on the bone volume here, we had like less than 3 millimeters of the bone, so it was very, very. We needed to be very precise. We use these kits from Meisinger, and we completed with piezo surgery and some osteotomes. But all we do is, like you saw on the first aesthetic case, all we do, we enlarge the bone from the inside without touching the periosteum, without doing any flap, without doing any damage to the soft tissue. Of course, here we took some pictures with different expand kits that we are using. So we expanded from the interior. Of course, there is a controlled fracture, but as we have no flap at all, there is just something that is protected by periosteum as its vascularization. Sometimes we don't need to insert some granules here, sometimes we do. So this is the final aspect. So we basically enlarge mesial and distal to the place where we wanted to place the implant, and then we just inserted the implant. So this is how it healed for both the implants. The same concept of the open healing. So we leave open. We don't try to put the free gingival margins of our incision back in contact, because otherwise we get too much tension. So you can see it's less than 3 millimeters, but when you go deeper, you have a wider situation. So we had to go like 6-7 millimeters and then split it from the inside, and this is our final result. Another case after ortho treatment, the same concept, but we had a much wider gap here, so we were forced to use bios. Again, the key of that is the placement of the Polish neck above the bone and above the level of the bone that we are trying to get the final bone result, and then suture it with no tension at all. And our tissue level implants are maintaining the distance between the splitted buccal and lingual bones, and also the contour of the tissue. This type of minimal invasive surgery is generating no pain at all to the patient. So basically, your patients are becoming your very, very good friends after this type of situation. And you don't do any other intervention at all. In the end, you just mount the abutments and then take impression, and that's it. And also, the soft tissue is healing directly around this tissue level implant. So the CBCT scan, you can see here, it's like 2.35, something like that. And the final situation with the patient. All the pictures for this are in our separate module. I just want to give you just an impression of how we do the bone splitting. Now, instead of conclusion, what does open healing mean? So basically, open healing is just a different type of closed wound, and we do not make any tension. We do not touch the periosteum. This is our main goal in our everyday practice. Why tissue level implants? As you saw, we can go flapless in pretty much most of the cases, and then we are not going to touch again the soft tissue around the implants. So it's generating, as all the recent researchers that let's say encourage the bone level users to put their final abutment that is not going to be unscrewed. You know, the last of the New York University concept, the skin concepts, and all these things that they are doing together with Dr. Chu and Professor Dennis Turno. They are practically transforming bone level implant into a customized tissue level implant, and they are not touching the implant at all afterwards. So we can achieve predictable aesthetic results with these implants because of their design and shape, which is very positive to the soft tissue and hard tissue. And we can respect the biological width, similar to the natural teeth. So this is our, let's say, short list of beliefs in our everyday practice for the minimally invasive way. Open healing protocol in the surgical stage, even it's just one socket or it's an extended, let's say, surgery, as you saw earlier. All the time, we use tissue level implants and flapless when possible. Again, I'm not saying that you cannot get at least the same quality of results with bone level implants, but this is how it's working in our hands for the last 10 years. And all the time with the respect of the biological protocol. So basically respecting the biology. We learned from the past, as you know, everybody started with tissue level implants many years ago. Then we watched the present, and hopefully we are creating the future. We have some discussions also with Tri on customizing some of these ideas for the better use for the patient's aesthetics and functional stability. And this is now the full face of our patient that we start with, and behind this beautiful smile there is always our team, and it should be a teamwork. Thank you very much for your attention. This is my team. Special thanks for this guy. He was born in Greece, Dr. Panagopoulos. We do the surgery together. Here is me. 1, 2 endodontists, and 4 other doctors that are working in our office on different, let's say, cases. Thank you very much. And here is my email address. If someone just wants to get any other information on cases with this type of minimally invasive that you saw some brief ideas today, I am very happy to share ideas with you in a way or another.
Thank you, Alex. I turn on my camera and I switch shortly to my presentation.
Okay.
Okay. Thank you so much, Alex. It was an amazing presentation, and first of all, incredible pictures. I have to admit, I barely saw these like really so beautiful pictures. It's not easy, we all know that, and yeah, and very interesting topics and cases. So I would like to start a little discussion round. It's like this. We have a lot of participants. I see now a few raised hands.
Your wonderful presentation, and I love to the tissue level concept. I want to ask you two things. The first thing, how do you manage what is your drug protocol during your open healing in big defects, as the one you show with the titanium mesh? What kind of antibiotic and for what so long are you giving these drugs to your patients?
Okay, yes. I answered to your first question right away. So basically, we gave our patient the antibiotic with like 30 minutes before the surgery, because it's the best timing for having the antibiotic in the blood. Then they continue for 5 to maximum 7 days, depending on the situation. We usually use the clindamycin or augmentin, but we prefer clindamycin. We only combine it with metronidazole when we have severe problems on sinuses. Otherwise, we do not. In the first 24 hours, there is a local, let's say, a local control of the site without chlorhexidine. So the chlorhexidine is going to be allowed after 24 hours because we don't want to generate any stopping on the new formation. And then the patient is coming to our office for controls in the next 3 weeks. After 3 weeks, we cut the sutures, and this is it. They should not, they should avoid, let's say, some food containing milk or all these derivatives from milk in these 3 weeks until the wound is starting to close, not to encourage the bacteria on site. And pretty much that's it. And then after the second day, they start with the chlorhexidine, either rinsing, and also we have this chlorhexidine gel.
Okay, thank you, Alex. I don't know if you hear me now.
Yes, I can.
Are you hear me, Olga? Yes. Okay, Alex. I have another question. I guess I understand you are placing large implants in the aesthetic zone.
Yes.
Yes. And I want to ask you if you're not afraid to make too much on the buccal plate of your implants. What do you think about that?
Can you repeat? I lost one.
You are putting large implants on the aesthetic zone when nowadays we are thinking about less titanium and more bone and soft tissues on the aesthetic zone. And I'm asking you if you are not afraid of too much compression on your buccal plate with the large implants.
Yeah, I understand. Usually for the maxilla, the bone is, let's say, not very dense, and especially when we regenerate the buccal bone with bios, then it's quite flexible. Of course, when we see on the CBCT or we feel after we make the first and second drill that the bone is very, very hard, then we take some more precautions. And of course, it's not necessarily all the time that we need to expand the bone from the inside. If the healing of the bone and soft tissue after our initial surgery was generated enough volume, we just place like a regular 4.1 implant, and that's it. But usually when we see that there is a depression and we want to have let's say an aesthetic full rehabilitation, then we are trying to enlarge the bone and place a higher diameter implant, respecting the particular situation of each patient. So yes, if I need to answer the question from the, let's say, mainstream point of view, it probably can generate more stress. But if I answer the question from our experience, we didn't have problems of losing the buccal bone after this maneuver since we started doing it. So I'm confident that it's a good idea for this concept. But of course, we are all the time, let's say, considering the local situation for each patient.
Okay, we have several more questions. Thank you, Luis Bessa.
Looking forward to meet you anytime.
Okay,
Thank you. Thank you.
So there is a question from Adarsh Pisharodi. He asks you, hi Alex, what is your preferred cement in cement retained prosthetics?
Okay.
Prosthesis, right?
Yeah. If the prosthetics are done with a zirconia frame, then it's highly opaque, and we can easily cement it with glass ionomer cements. We use in our office something from GC. If from some reason there is, let's say, only one, it's a crown in the aesthetic zone, and we do it with Emax, then we just use the recommended cement for Emax on titanium, which is, I think, Variolink implant. Depending on the country, it has different names. I'm not very confident that there is any addition between titanium and Emax, but it's for the aesthetic zone. It's the right thing to do, and you can try it in with the trines directly on the abutment. Now, I hope that TRI is going to develop also abutments for this concept with anodized pink. So basically, we will soon have a better solution for that, and also some customization solutions. But we use this glass ionomer and composite Variolink from Iboclass.
As you know, we are really fast in developing things, and we are working always on getting solutions for you. So there's another question, just to let you know, we have all the starters of the question, and also Dr. Ionescu can answer them in a follow-up via email. But I would like to, because we tried to put Reggie before into the conversation, and she had a question about, please can you explain your atraumatic extraction, and then the second question was, and then the open healing protocol. So
yes, I will just briefly say something about traumatic extraction. So what we need to achieve is not to lose buccal or lingual or whatever bone during our extraction. And for that, if we have a bicuspid or a molar, we need to cut them and take out root by root. If we have a monoradicular, there is a concept of cutting the root from buccal to lingual, such as when you try to fracture it, you press to the mesial or distal. So we never press on the buccal or lingual bone. So we need to spend as much time as possible with the extraction, not to lose the additional bone. Now, regarding open healing is a huge topic. So
yes.
The only concept is that first we do a traumatic extraction. Second, we insert a biomaterial. Then we put a membrane that we are just suturing it to the free gingival margins without any flap, without any tension. just take care that not any membrane are, let's say, suitable for that. They need to resist at least 2 weeks in the mouse.
Thank you, Alex. Just to let you all know that following questions, if you have more questions, please type them in the question folder. We're going to answer them after the webinar. And because we're running out of time, I would just like to take another 2 minutes to give you some information about what is going to happen with Tree. So I'm really already happy to have the next announcement for the next Tree webinar, which is taking place on the 2nd November. Here with Dr. Kamm, which is from Germany, and the topic is going to be techniques for immediate loading to achieve superior aesthetic results, which is a quite interesting topic in our days. Then if you want to meet us in personnel, the next stop for us is going to be in Paris, the ARO, where you can find us in the booth S13, and you are all welcome to have our meet us in our booth and have a drink with us and a chat with us, and yeah, test our products also at the booth is possible. Please come and see us in Paris. Then I want to give you the information of this very interesting master course with Dr. Marius Steigmann, also from Germany and also Romanian. So he is going to have this Model 1 course. It's a 2-day course with soft tissue management, which is very interesting and fitting to the topic we had today. And then always interesting for you is to be a follower of our Facebook site. So please just click a like on our Facebook site. So there you are always up to date. We're going to present there every month a case of the month, for example. You can see what is happening with Tree, what new products we have. And that's my last words from my side. And I say thank you as well. You are always welcome to ask following questions over the homepage academy@treeimplants.swiss or also at info@treeimplants.swiss, and you can always contact me. And I say a big thank you again to Dr. Alecsandru Ionescu. Thank you very much for this amazing presentation. Yeah, thank you.
Thank you.
Thank you. Okay, bye. We shut this down. Bye.